The major problem in all chronic diseases is patient compliance. We can prescribe many things, but it turns out that patient compliance is really one of the major problems that people do not do well. In addition, we really could use treatments that would be easier for the patients with less complications and which would have a greater impact in reducing the complications. Diabetes is a chronic disease. It's very hard to get people to manage it long term and really get the kind of outcomes that are necessary to reduce complications. So we need to work with the patient. What I always say to the people I teach is you have to prescribe something the patient is willing to accept and follow. So you have to talk to the patient and sort of make a contract with them, because you can prescribe anything you want, but if they don't take it, it doesn't work. The most important part of glycemic control and weight loss is the patients have to follow a lifestyle program. If you don't follow a lifestyle program, what will happen is you'll take more and more medicines, you'll get more and more obese, and the medicines will be less and less effective. The most effective treatment in type 2 diabetes is to have a patient on a lifestyle program to which you add drugs, and the combination will give you very good control. In the type 1 diabetic, on the other hand, then you need a diet that the patient can comply with, that will fit with the insulin regimen. All right, in addition to all the new clinical information which has been presented, there was a great emphasis on the personalized care of patients with diabetes. What we mean by that is to try and find what the cause is for each individual patient. We now know that diabetes really is many different diseases. There are gene abnormalities involved in many patients, and if we can figure out what the genes are that are abnormal for each particular patient, we can then target the treatment. For example, there is a disease called neonatal diabetes. We now know that it's due to a genetic abnormality in the KATP channel in the beta cell. These children used to have to receive insulin. Now we know that sulfonylureas, which will benefit the KATP channel abnormality, are the drug of choice, and so the treatment paradigm for them is much easier. That model, we would like to think, can extend to many different people with diabetes who have other genetic abnormalities that we can specifically treat. We have to find what they are for the individual patient and then develop the specific treatment. That emphasis was really a major part of this meeting to introduce the concept to most of the practicing physicians.